just start with a few words, and then we can start with the presentations. So for those who don't know me, I am Andrea Dardis. I am the vice chair of the IWGGD, and we organized this webinar together with my co-chair, Professor Gheona Altarescu. So we decided to organize this meeting about pre-implantation genetic testing to reduce the risk of Parkinson's disease. We have 3 speakers, and I would like to thank the speakers for accepting this invitation. So we will have these 3 presentations and a discussion at the end of them. So you know, everybody knows in this audience that B allelic mutations in GBA1 gene leads to Gaucher disease, but monoallelic mutations leads to an increased risk of the development of Parkinson's disease. So in this context, physicians and healthcare professionals in general dealing with Gaucher disease now have to care not only patients affected by the disease, but also with the relatives that might be carriers and at risk of Parkinson's disease. So in this context, there are a lot of new challenges in the diagnostics, genetic counseling, ethic issues. So we thought that this is an important subject we need to address as a group. So that's why we decided to organize this meeting. So I would like to thank also Gheona Altarescu, because she was very persistent and in organizing this meeting and get this meeting done. So I would like to introduce her. She's a professor and works at the Shaare Zedek Medical Center in Israel. She's the director of the Preimplantation Genetic Diagnostic Unit, and she will, in this first, will walk us through the PGT techniques and other prenatal testings approaches. So, Gheona, the floor is yours.
Thank you very much. 1 minute, I will share my presentation, 1 minute. So, thank you very much first for this opportunity, Andrea. As I mentioned, actually, it started from Professor Ari Zimran idea, and the idea is whether we should prevent the risk, the increased risk of Parkinson in GBA carriers by performing preimplantation genetic testing. And together, both me and Andrea, we think that we should develop maybe some guidelines being part of the international Gaucher group organizations that is developing different types of guidelines. It is also important ones regarding not only prenatals, that also I'm not sure we have clear guidelines, but also for preimplantation genetic testing. So I will say more in general what is preimplantation genetic testing, mainly for the audience that is less used to this type of technique. And then Professor Avner Hershlag from United States, he is an IVF physician, also very much involved in preimplantation, but also in ethical aspects, late onset disorders. So he will speak mainly about the issue of preimplantation genetic testing in late onset disorder. And after this, we will have the ethic talks from Professor Eline Bunnik. So I want a bit to say why this interest came to us. In Israel, I'm working in this hospital, Shaare Zedek Hospital Medical Center, and our preimplantation genetic unit was initiated in 2004 We offer also preimplantation genetic testing for additional seven other IVF centers from Israel. So we are a relatively very large unit that are performing PGT for molecular disorders, for chromosomal abnormalities, and also for screening the number of chromosomes of the embryo. It is called PGTA, to reduce the risk of having a baby or a pregnancy with Down syndrome or other chromosomal abnormalities. Since 2004, we performed preimplantation genetic testing for around 1,200 different genes, 7,000 cycles, and more than 2,000 healthy babies born. The story, actually, the breakout and the possibility to perform preimplantation genetic test, it started actually a long time ago in '68, when first embryo was performed on biopsy was performed on a rabbit embryo. But then it started the idea to develop the possibility to test embryos that are developed by IVF already in the mid 1980, and the first case was a patient that Professor Handyside from England performed preimplantation genetic testing by testing one cell of 6 to 8 cell embryos of day 3 after fertilization, and several other pioneers were Verlinsky and Kuliev. So preimplantation genetic testing involves actually testing of embryos that are obtained by IVF, and to test them for a specific genetic disorder or chromosomal abnormalities before they are transferred to the uterus, therefore enabling selection of embryos that are free of specific genetic abnormality that is known from before, and to prevent the birth of the child with a genetic disorder if the parents are known as carriers or one of the parents is affected. As I mentioned, there are 3 types of preimplantation genetic testing. One performed for molecular disorders like Tay-Sachs, cystic fibrosis, and here obviously it comes also the issue of Gaucher disease, preimplantation genetic testing for monogenic disorders. Then the other one is from chromosomal translocation or inversion or other structural abnormalities, and as I mentioned, the aneuploidy screening. So there was a significant evolution in the way that I think more ethical aspects of, to which patients we should offer PGT. So in the very beginning, it was considered that such a test, such a technology should be used for conditions with no effective treatment, very early death, severe mental retardation. Yes, we can think about Tay-Sachs, Duchenne muscular dystrophy, spinal muscular atrophy. Also now for spinal muscular atrophy are starting to have genetic drugs. But anyway, gene therapies. So very severe disorders. Obviously in this one, we cannot include Gaucher type 1 and definitely not only carriers of Gaucher type 1. But it evolved. After this, it was also performed for HLA matching. It means that there is a child at home that is affected with whatever disease and it requires bone marrow transplantation. And then there is no available donor. And then you can do preimplantation genetic testing and to choose an embryo that is totally matched to the child that is waiting at home for a bone marrow transplantation. And obviously, again, here there are ethical issues. Do not want too much to go into them, but again, if the parents really want this child because they want this child, or only because this is the only way that they can help save the affected child that there is already at home. And then again, and after this also adult onset condition, and between this I think we'll hear much more from Professor Hershlag, but again, you know, whether to perform or not for risk of cancers. Again, not everyone that is a carrier of a genetic mutation in one of the genes that increases the risk for cancer will develop cancer. So again, should we perform for it today or not? And also there are treatments that are pretty effective in our days. So therefore, there is a slippery slope now, you know, allowing more and more to perform for PGT for diseases that in the past were not considered that this technique should be used, but today it is definitely used, approved in many countries, including in Israel for all this, what I presented you before. It is legal to perform in Israel PGD and in many countries. Who are the couples that are performing it? Either they know that they have a genetic disorder, carriers, or one of them is affected, or again, the women that are over age 35 and they are performing anyway IVF and they want to know that the embryo is euploid with 46 embryo, recurrent pregnancy loss, and chromosomal abnormalities. The process, why am I presenting it? Because actually I want to present also from the point of view of IVF a bit and from the point of view of the lab. This is not an easy process, not for the couples and also not regarding the lab technology. So it requires also from the patients and also from medical point of view significant workup. So there is a stimulation and retrieval of the oocytes, the fertilization, and then an embryo is biopsied at day 3 or at day 5 usually. Today, mostly at day 5, there is a biopsy of several cells of this embryo. I have to stress already that there are many already papers that are showing that biopsy of the embryo does not cause any additional genetic malformation. So this is a question that everyone is asking. No, there are not, due to the biopsies, there is not an increased risk of genetic malformation of the babies. Then there is a genetic testing that today we have better methodologies that we have had in the past, and then hopefully the transfer of I don't like to say a healthy embryo because it's not that we can test for every disease in the world and to be sure that the embryo is healthy, but to be sure that the embryo is not affected with the disease that we tested. So we return an embryo that is not affected with the disease. So between the limitation, and you can see there are several here limitations. I want in one slide to show you the issue of diagnostic accuracy, because again, this requires a lot of lab work before starting the procedure itself. So the main issue regarding the molecular testing in lab for all these that have PGD for a molecular disorder, again, Gaucher is included here, is a phenomenon called allele dropout, meaning that when you have a very small amount of DNA, we are speaking here about 3 to 5 cells, yes? When we take a blood test, we know to perform a genetic test of a molecular disorder, we have a significant amount of DNA, yes, of thousands of white blood cells that we extract DNA. Here we have a very small amount. So there is a phenomenon that when you do an amplification of the mutation, not both alleles will show up in our test. Only one of them. This is called allele dropout. Again, this is kind of an artifact due to the small amount of DNA. And then there is a possibility that we will not detect the mutant allele. Therefore, it will cause a misdiagnosis. So there is a way to prevent it, meaning that we perform several markers surrounding the genetic mutations that increase accuracy to 99%. But this, again, means a significant workup in the lab to set up all this familiar testing. It is per family and per gene. So each family has to have a kind of a setup. And even today that we have modern technologies based on next generation sequencing, that you can see entire chromosome and look at specific genes that you are interested. Again, this setup needs to be done. And this is done in all the countries, no matter where, before we start the PGT, in order to ensure that we have enough accuracy by not missing the allele dropout. So this is labor intensive and expensive. And I want also to stress that in general, for recessive disorders, carriers are transferable. So indeed, we recommend transfer carriers of cystic fibrosis, of Tay-Sachs, and many more. And here, of course, is the issue of Gaucher disease being a recessive disorder. So the benefits are obviously higher success rate and of pregnancy with a healthy child regarding the disease, reduce the emotional burden. But as you understand, there are limitations, including the requirement for IVF, even for couples that are fertile. Also, the accuracy is very close to 100%. I think today it's around 99.5%. There are still so many factors between the IVF and the genetics and the very small amount of DNA that you cannot really give 100% accuracy, maybe the most 99.5%. And at least in Israel, we recommend a confirmation by prenatal invasive testing, CVS or amniocentesis. And this brings me to tell you that several couples, obviously, you know, we are always guided by our leader in Gaucher disease, that Professor Ari Zimran. So we discuss these couples with him before performing PGT. But this one couple specifically, the male, the husband was a compound heterozygote for the milder mutation and more severe mutation. And the wife was not carrier at all. So meaning that all the children will be carriers. And they required IVF anyway, disregarding to Gaucher disease. They had fertility issues. And then actually what they asked is to perform PGT and to transfer carriers of the mild mutation, because again, the risk for Parkinson will be less than the risk for Parkinson if a carrier of 84GG will be transferred. So we performed, in this case, 2 cycles, and the child was born with a carrier of N300S. The second couples were both carriers, again with a milder mutation and more significant mutation, and they actually wanted only wild-type embryos. Again, even not carriers for the N370S. So first child came after 2 PGT cycles, second child, 5 PGT cycles, and then they wanted the third child and no pregnancy after another 5 PGT cycles. Again, we discussed with them whether we should return the N370S embryo, and they didn't agree to it. So again, you know, this is also the ethical issues. What are we doing with this embryo? They will be kept, they will be destroyed, and so on. Actually, these are people that are supposed to be healthy, but a higher risk to develop Parkinson. And this is the idea of our meeting today, to understand it better. So it's important, obviously, the ethical debates and the genetic counseling from this point of view. Obviously, there are pros and cons. The pro is still there is no, exist today, maybe in 20, 30 years it will be, maybe even earlier, but today there is not a very effective and good treatment for Parkinson. But there are many cons, including the IVF, it is a late onset disease. As I showed you, a lot of genetic work time. Still a very small but possible misdiagnosis. And again, hopefully new effective treatments for Parkinson will appear in 20 years. What I want to tell you is that a very, very hot topic today is preimplantation risk score selection. We are involved in kind of research in this aspect, ethical mainly, but not only. And I know that Professor Hershlag is also involved in this also from what is he very interested in, the ethical aspects of this. So this is actually a tool that is analyzing embryos for risk scores for common adult-onset disorders like high blood pressure, cardiovascular disease, diabetes, and they can rank the embryos, the ones that will have more risk for diabetes or less risk, or more risk to develop a cancer or less risk, and based on this to recommend to transfer a specific embryo. Also, again, we don't have here a monogenic specific disorder. Again, as I mentioned to you, for cardiovascular, metabolic cancers, and so on. So, for instance, an embryo showing an 80% higher than average risk for diabetes will be deprioritized for transfer compared to an embryo that has a lower risk for diabetes, and so on. And again, you know, where is exactly the limit, and should we perform preimplantation testing for risk reduction score in these cases? So, of course, there are limitations even in this, although there is a risk reduction, but the absolute numbers are small. These tests, we don't have long evidence data. There are more calculations that are mathematically performed, but no long data by now to prove that what we think is really correct. These models are based on certain ethnicity, does not include all types of the population. And this also obviously is raising very significant ethical consideration. But still, there are two companies today in the United States that are performing it. So the question again is, if already some companies are performing for reductions the risk of multifactorial disorders, whether it is, should we recommend or not to perform it for a risk for, in a case of a monogenic disorder for Gaucher, like Gaucher, for the risk of Parkinson disease, to decrease the risk of Parkinson disease. So there is a question of the technologies that definitely exist versus the ethical consideration. We all in these fields know that first, do not harm. So this is a question. Are we doing any harm by performing PGD or not? And I'm looking very much forward to hearing more from the ethical presentations that we will hear. What I want to say is that it looks that in the run for the perfect child, that today everyone is looking for them, including this risk score reduction. The question is we will find in embryos that is good enough to be transferred. This is, I think, a very important question in our days with the polygenic risk score. And then I leave you with the question, if should we perform PGT for risk reduction for Gaucher disease? Yes or no, or there are many in between, 50 shades of gray or even more. And thank you very much for your attention. And I understand that we will take, discussions will be in at the end. So this is now, the next presentation will be given by Professor Avner Hershlag. You are on mute. Avner, you are on mute.
Not anymore, right?
No, yeah. You'll share your presentation now, yeah?
I will try.
Yeah, good.
Done. Hold on 1 minute. I'm sorry. Yeah, I can't open. I always open it.
Test.
What?
So should we ask meanwhile the next speaker, and then you want to, yeah?
Yeah, why don't you do that? Yeah.
Okay, and then you'll solve hopefully.
Yeah.
Okay. So we will go now to the next, the ethical.
Yes, I can do that.
Yes.
I'll go all the way up. Just gave away my discussion points. I hope that you can see my slides now.
Yes, we can see them, but if you can put it in presentation mode, it will be easier. Great, thank you very much.
Yes, okay. For me, it's in presentation mode now, hopefully for you too. So yes, my name is Eline Bunnik. I'm an associate professor of medical ethics based in Rotterdam in the Netherlands, and also the chair of the National Indications Committee for Pre-Implantation Genetic Testing. I will talk about that later. But first, I wanted to discuss with you what could the problem actually be from an ethical perspective, because sometimes I wonder too, not only what is the problem, but also what could possibly be the problem, in the sense that PGT allows couples, of course, to make informed choices about avoiding serious medical problems in their offspring, and as compared to existing alternatives such as prenatal diagnosis and then potentially termination of pregnancy, PGT, because it happens much earlier in the process and before we realize a pregnancy, it is from a moral perspective maybe clearly preferable in many ways. It helps, it spares women and their partners the burdens and the impact of becoming pregnant and then having to make the very difficult decision of terminating a wanted pregnancy. So in many senses, it is so much more beneficial than what we've had available otherwise. So what could be the problem? I was thinking of this discussion, and I think that these three sets of ethical issues are most prominent in this discussion. So one is the protection, the imperative of protecting human embryos. The second is the slippery slope argument, and the third is expressivism, or the expressivist critique. And I will briefly discuss these three. sets of issues. So first, the protection of human embryos. Basically, this urge, this imperative to protect human embryos, in my view, I think it comes in two flavors. One focused on the dignity of human embryos and one focused on their interests. And if you've had a little bit of background in ethics, you can maybe recognize that dignity is a deontologic approach, an approach that focuses on rules and fundamental principles. And interests, the interests of human embryos, that's a utilitarian approach, an approach that focuses on the consequences, and that is focused on maximizing good consequences and minimizing harms and adverse consequences. So first, if we look at that deontological approach, the approach that aims to protect the dignity of human embryos, I think a good example is Germany, which until 2011 had this Embryo Protection Act in place, which forbade the fertilization of an egg with any aim other than to transfer it to a woman's womb. So in Germany, clinicians and researchers, as you may be aware, were not allowed to create embryos and surplus embryos. So every embryo that was created in the context of a fertility treatment had to also be transferred to the woman's womb, which resulted in the German rule of 3 and the birth of very many triplets at that time, because it was felt that it was wrong to discard, to throw away embryos. That was felt to be contrary to dignity, to that absolute inherent moral worth of embryos. But the second rationale for maybe protecting human embryos is a utilitarian approach. And this aligns much better with a gradualist approach to the moral status of human embryos. And the idea basically is that we owe human embryos protection to the extent that they develop interests, that they develop, because we tend to look at sperm or eggs that are often discarded in natural situations by the millions, sometimes every day, if we look at sperm. And also in women, of course, every month an egg cell is just thrown away by nature. And that is not a problem. It is the moment in which the egg and the sperm come together that something special happens. But although some people feel that at that very moment, the embryo already obtains moral status, many other people feel that there's actually a gradual increase of moral status as the embryo grows. So at the very end, only when a child is born, it becomes a person, also in a legal sense. And at the very other end of the spectrum, we have these sperms and these egg cells. But along the way, somehow, somewhere, the human embryo starts to have moral status and starts to be worthy of our protection. And in many countries, we have that 14-day rule that sort of expresses this gradualist approach, the idea that you can continue research on human embryos until they are 14 days old. But we also see that these lines that are drawn are not fixed. We can see that in the in the UK, in England, and also in the Netherlands, there have been calls, not just by interest organization, but also the Health Council of the Netherlands, which is an authoritative body that advises the Dutch government to extend that 14-day rule and turn it into a 28-day rule. And I think that there's this gradualist conception that underlies this, that would allow, in theory, also maybe later moments in which you could start to ascribe moral status. Jeremy Bentham, over 200 years ago, asked this famous question about animals, actually, but can they suffer? And if animals have the capacity to suffer, then they become our moral patients. Then we need to protect them in some way. And the same question can be asked of human embryos, maybe. Can they suffer? At some point, we feel that they can. An embryo of 20 weeks old, we feel that it may be able to suffer. And then a 3-day embryo, maybe not. And somewhere in that middle, they start to develop this capacity and are worthy of our protection. Let's move on to the second set of issues, and that's the slippery slope argument. Designer babies. The idea that we've developed this technique, it's a medical technique, it's a technique that is used by medical doctors, but we can technically apply it also to non-medical purposes. And there's this is not science fiction. I saw this a couple of years ago for the first time. And this is actually happening, but this is the notion that if we start to maybe not stick to our strict frameworks for allowing PGT to happen, we may end up using it also for these types of purposes. And well, the notion is that PGT wasn't invented for these purposes and may not be acceptable for these purposes. But the slippery slope argument is a fallacy. It's not a valid argument. It takes the form that when we start doing something, we inevitably end up somewhere else. But empirically, this is not true, because the sequence of events between starting here and ending up there is not causally determined. We can make hundreds of decisions in the meantime that will help preclude that undesirable conclusion. So the slippery slope argument doesn't really hold. And then there's expressivism, the expressivist argument, expressivist critique, the idea that if we use these sorts of technologies, we are actually expressing this value for existing people living with these disabilities. And you can see this concern expressed in a woman who was a carrier of a BRCA mutation, saying, "Doesn't an embryo with a gene mutation have a right to live? I was once an embryo like that, and I am alive now, and I am happy now." But this expressivist critique is often associated also with concerns about stigmatization and discrimination of people living with disabilities, or maybe the disappearance even of people with disabilities from societies, and consequently reduction in the level of and quality of care and support for these people. In the Netherlands, actually, in 2008, our government almost collapsed over PGT. There was a lot of opposition to the introduction of the technology in the Netherlands, and this was ultimately settled by the introduction of strict regulations in our country. And I'm presenting this mostly as an example, but we have this regulation in place for pre-implantation genetic diagnostics, as it was called back then still. We have only one center in our country that conducts PGT, about 600-700 couples per year. And PGT is permitted only when there's a high risk for a serious genetic condition. And this standard is used across many countries, actually. But the Netherlands has also installed a national indications committee. It consists of clinical geneticists, gynecologists, ethicists, patient-parent representatives. It meets a couple of times a year, and it evaluates all new medical indications, so all indications for which PGT was never before requested. I'm chairing this committee, and we formulate advice. We've done this from the very beginning in the form of no unless or yes on the condition that. So it's always conditional. And the idea is, especially the no unless, is that we sometimes say to a couple that is requesting PGT, and you will be aware that they will not do this for no reason. They have their own experiences with the disease. They really want to prevent the disease from happening in their offspring, and they've gone through gynecologists and specialists. They've gone through that one specialist center in which they've received the counseling, and they want to go ahead. And sometimes, in about maybe 25% of the cases, 1/3 sometimes, we say no, but we always formulate it as a no unless. So there may be reasons for the team of healthcare professionals to make an exception. So even if we say no, the healthcare professionals in Maastricht can sometimes say, okay, but in this family, the condition is expressed in an atypically very severe manner, and we are concerned about the consequences for the offspring. So in this case, we will still go ahead with PGT. So there is some space to move in the consultation room. Last year, we wrote a paper in which we compared these approaches to the regulation of PGT across 7 European countries. And in the UK and in the Netherlands, we have this medical indications model, but there's different models too, and individual requests. Some countries have committees in place, regional committees, multidisciplinary teams that evaluates each and every PGT request. Doesn't matter if it's new or not. The bottom one, the clinical assessment model, we called it. Some countries just leave it to the discretion of the healthcare professional whether or not PGT is allowed. But in all these 7 countries, we still have that standard of PGT is intended to prevent disease in couples that have a high risk of passing on a serious disease to their offspring. So seriousness, severity, high risk of a serious disorder, that is one of the most important guardrails against that slippery slope towards designer babies that really keeps PGT and its application in check. But seriousness is a difficult concept. Seriousness and severity is used interchangeably, although you can maybe see a little bit of a difference between the two concepts, where seriousness feels like it refers to the qualitative experiential aspects of a condition, and severe sounds a little bit more quantifiable, a little bit more objective, a little bit more associated with the biomedical aspects. But seriousness is so difficult to define it. There are no good definitions. There's no consensus on what it means. I think what is the most important problem is that it is so individually determined. It's really hard to make at a population level assessments of severity. It is such an experiential, difficult, intractably difficult concept. In Kleiderman and colleagues last year in the European Journal of Human Genetics have tried to unpack that notion of severity, seriousness. You can see it in the center. But it really depends not only on the medical, biomedical characteristics of a condition, but also the availability and accessibility and affordability of treatments, of course, but also accessibility, availability of support. So even if there is a condition and there is no treatment, but there's adequate support systems that can really affect how severity is felt and experienced at the individual level. So it's difficult to operationalize this. How do we do it? We wrote a paper last year, and by analyzing the minutes of the National Indications Committee over the past 15 years, we saw that we're sort of circumventing it. We're rarely ever stating this is a disease that is serious enough, or this is a disease that is not serious. We circumvent it, and we talk about variables, characteristics of the disease that will affect subjective notions of severity. We'll focus on the risk. We'll focus on penetrance. We'll talk about how the condition manifests, the degree of suffering that is associated with it, functional limitations that can arise, complications, the frequency of hospital visits, and the variability of expression. We talk about all these other things. This is a list of types of diseases, and then you can see in how many of the cases, in how many of the requests pertaining to the type of disease, we've given a yes or a no or an advice. And so you see that for craniofacial disorders, we've always said yes, but for hereditary heart and lung diseases, for instance, we've also quite often said no. This is Gheona's paper, and this is the topic of today. And what I find interesting is that because the couple already needed IVF, the question of whether or not to apply PGT is much different. And this I recognize from studies that were done also in the Netherlands, of combining pre-implantation genetic testing for more than one condition. And I think that helps us out partly because the rationale of that standard that we talked about, that high risk of a serious disorder, the rationale is that we should seek a balance between the benefits for parents of being able to use this technology against the issues and concerns that make it a morally sensitive technology. We talked about a duty to protect human embryos. We talked about the expressivist concerns, but we're also here talking about the burdens and the costs and the manpower that is needed from healthcare professionals and the time it takes. But all of that has already been accounted for in parents who already have to make use of IVF, ICSI, or that already have an approved, in our country, approved indication for PGT. If that is already off the table, then it becomes proportional, I think, to add risk reduction for Parkinson's disease. But that's thanks to that notion of contextual proportionality. And now to consider PGT as a standalone test for risk reduction for that risk of Parkinson's disease that is associated with these Gaucher disease genes, I think is much harder. If we look at reports for public support also, for late onset diseases, we see that there's much less agreement for adult onset diseases for the use of PGT than for childhood onset diseases. And to the exception, Israel may be an exception here, because we see much more positive attitudes towards PGT in a less stringent way in Israel. But this is my final slide. Contextual proportionality, yes. In cases where we're already initiating a fertility treatment, we're already initiating PGT, I think that it would be acceptable to, at least in my country, it would be acceptable to add risk reduction for PGT. But as a standalone test in my country, it couldn't pass the test of that high risk for a serious disorder standard. I'm expecting. But there's more questions to be asked. Should age of onset matter? I think that, Gheona, you made a very good point when you said that 20 or 30 years from now, there may be treatments for Parkinson's disease. So what problem are we actually solving at this moment in time? And also, how does age of onset matter in the sense that diseases that are associated with loss of sensory abilities, for instance, it's really not that clear whether it's worse to have that disease from the moment when a person is born, or when that loss of a sensory capacity happens later on in life. For many people, when they are born with a disability like this, it's easier for them to adjust, and they sometimes, depending on the condition, but may report higher quality of life than those who are affected only later in life. So how does onset really matter morally? And when also maybe is risk reduction significant enough? We can do, for Parkinson's disease, we're talking about a 15-fold increased risk, so if I understand it correctly, associated with the most severe alleles, but a 15-fold, does that surpass maybe, does that give a more than half lifetime risk of developing Parkinson's disease, and how much would we be able to reduce it so that proportionality becomes favorable? And there's other issues too. Indeed, can we transfer embryos that we know do have a remaining risk? And what about the child's right to an open future in that case? If we're sort of stacking all sorts of information on a child already at birth, which could possibly be a burden for them. So these are some points for discussion for later. Thank you for now.
Thank you very much for this excellent and very clarifying talk in some aspects. So I first of all, I apologize, but at one point my internet connection just went off, so I lost the beginning. I don't know, Gheona, what you have done with the program, but I guess...
Yeah, what happened is that Professor Hershlag could not upload his presentation, and after 2 or 3 minutes, we thought maybe instead of waiting more, he will solve his problems, technical challenges.
Yeah.
And that's why we switched.
Okay, perfect. Yeah, I as I said, I was off for a few minutes, so thank you, Gheona, for taking care of this. So I now probably, Gheona, you want to introduce Professor Hershlag. I think he's okay with the presentation. You are on mute. Yeah.
You are on mute.
You are on mute. Yeah.
So, as I mentioned, Professor Hershlag is an IVF physician from the Renaissance School of Medicine, Stony Brook University, New York, United States. He is very much involved into research, mainly ethical research in preimplantation genetic testing. He's performing a significant amount of preimplantation genetic testing in his unit from the point of view of IVF. And we asked him to give a talk about the issue of adult-onset disorders in preimplantation genetic testing. Avner, we don't hear you. You are on mute.
Okay, you hear me now, right?
Yes.
Yes.
Gheona, I sent you a copy. For some reason, Zoom is giving me a hard time. Can you open it on your end? And I'll talk in the meantime.
We see your desktop.
We see
Yes.
your desktop.
Oh, you do?
Yeah,
yes.
Because, till it will travel to Israel, even by email, we will finish the...
Wait, you see my presentation?
Yeah, we
Yes.
can see it.
Okay, good. Okay. So, thank you, guys.
Okay.
And I want to thank you for inviting me, and it's very interesting, the interaction with my European colleagues. Of course, Gheona and I have worked together for a long time, research and also presentations, but hearing Dr. Bunnik right now, I feel that we are really ocean apart when it comes to preimplantation genetic diagnosis. And it's really, really interesting to have the different perspectives. So I'll start right away. I was asked to talk about preimplantation genetic testing for adult-onset disease. I'm not going to talk about the Gaucher Parkinson debate, but just about ethical dilemmas that I've encountered and that we can talk about. Yeah. So, so just to start with, a patient of mine who himself has a myotonic dystrophy, the entire family pretty much has it. His brother, his father, 4 paternal uncles. And we have done PGTM on him. PGTM, for those who are not medical and watching us, obviously you've seen the introduction before. Genetic diagnosis on an embryo that's now day 5 or 6. We take out about 5 cells, sometimes a little more, sometimes a little less. We found a normal embryo. They conceived and they have, they already, I think, had a baby. And I wanted to start with this case because I want to say this is why we do it. And, you know, it's very interesting what Dr. Bunnik said, Professor Bunnik. You know, it's like, it sounds like in Europe, people, you know, in our profession and ethicists sit down and start discussing the severity of the disease. When I see a person who has myotonic dystrophy, I don't have much of a question. So the first question, the first ethical issue that comes up is kind of interesting with Huntington's disease. So Huntington's disease, the severity is well known, appears in midlife. And this wonderful patient came to me. Her father just passed away very recent before she came to see me. And she wanted genetic diagnosis on her embryos to make sure she doesn't have babies with Huntington's. However, she doesn't want to know if she carries the gene. And I'm sure my colleagues in other programs have had this experience. So this is Huntington's disease. As we know, it is the production of abnormal protein. It's called huntingtin. That's why it's called Huntington. And that is because I call that one of the stuttering diseases. That is a repeat of CAG. There's other in that family. And when the number of repeats is too high, you see here above 35, let's say, it starts making this abnormal protein and results in degeneration in the brain. And you see here on the left, the normal brain, a cut through the brain in the bottom, and the damage that the gene will do on the top. And this is the life course of Huntington's disease. You see that they have full functioning abilities when they're born, and somewhere between usually 40 and 50, they start having motor impairment, cognitive, and they have dysphoria, which is like a moving disorder. So she doesn't want to know. What is her right not to know? Of course, it's reproductive liberty. It's the doing this. She wants her child to have an open future. Families, if let's say they went along and they said, okay, it's a dominant gene, 50% chance that the child will have it. We're not going to test him. According to the American Pediatrics Academy of Pediatrics, the rule is that you're not supposed to test a child for genetic disease until she or he turn 18. Well, you can, I assume you can imagine the stress on a family that lost the grandfather, and now the child is, they don't know if he will have the gene, if he will develop in midlife a disease and then die early. So there is no real effective treatment also for Huntington's disease. And there are other predisposition genes that we're going to talk about. But with Huntington's, there's report of depression and suicide when you know. So for example, the question of you go through the PGD program or PGTM and the female patient, the mother, does not know if she has it while we test the embryos. Had she known, what would it have caused her? Let's say that she knows that she has Huntington's and she's now, as I presented, 33 years old. That nightmare that she's been through with her father will recur. And there are reports not only of suicide, or not only of depression, but also of suicide. So what are her options? The options when you have a history of Huntington's disease, one is not to have children, not to take the risk. The other one, to have natural children, which is 50% risk. Then you can get tested. And so she, the woman, does not know that she has it. Imagine that she doesn't carry the gene. Then she doesn't need any reproductive technologies, at least for now. And she can just go on and have children, and they are at a zero risk unless they have a de novo mutation. They don't have the risk of Huntington's. And of course, she can go through the PGTM, which is what we did. So option one is very straightforward, of course, and you can see the gene below. It's an easy test to do. And interestingly, you can say, well, wait a minute, if she gets tested and she's positive, what will it do to her? What will happen to her health insurance? We're in America, health insurance, my European colleagues and my Israeli colleagues, not so great. And what will it do in terms of employment? Had there been a leak of her disease, what will it do to this patient, which is really upsetting to even think about. So here is hail to Obama during the Obama times. 2008, can you believe it was so long that he was president? Well, we have the GINA Act, which is a nice, it's not the name of a patient. It actually means Genetic Information Non-Discrimination Act. And that is that employment, health insurance, they cannot discriminate because you're a carrier of a disease, no matter what kind it is. And what you can see is there is an office that you can actually appeal to if you have experienced discrimination. I don't know how that office performs in the current administration, but that's a different story. I think Gheona said no politics, right? So I'll stick to that. So the other one, which was an option that was available in my early days of doing PGD, is very interesting. It's a non-disclosure. So what you do is you do test the patient, obviously with all the technique that Gheona spoke about, which is to identify the gene, to develop what we call a probe. Sometimes we check the neighbors. I call that checking the neighbors, the neighboring genes, just to make sure that we have the correct test for the embryos. But then, of course, the people who are involved, starting from the embryologists, the nurses, the geneticists, the physician, like myself, all of us know, but the patient doesn't want to know. How do you not disclose to the patient? It is her request, but is it even possible technically? So, the patient has the right not to know. She is fearing discrimination despite the GINA law, okay? And we talked about the impact on her emotionally if she does have the gene. Every day she counts and she knows what's about to happen. She's seen that in her dad. What will happen to her relationships? What will happen to the way she takes care of the babies that we will help her have? So the other option, which I like better, and that's what we did in this case, is exclusion, that you can exclude all the embryos that carry what Gheona talked to as allele. The allele what it comes from the father. So she has one allele coming from the father, one from the mother. We know that he carries the gene because he is the one who had it and passed from it. So we simply don't. So the advantage is that we, and this is how, like, you have Henry has the disease, that's the star here, and Henrietta does not. That's a match made in heaven with the names, right? So anyway, so we don't use the alleles that come from Henrietta, and therefore we know that we will not have the disease. So this has to do with the right not to know, which our patients have. And it talks about, this is, you know, in the ethics territory, this is autonomy of the patient. And of course, in this case, it's actually a time bomb that you are, that she has in her genome. So it's kind of, with Huntington's disease, I call that a quadrilemma. There are four choices. First, do you want to know, or do you don't want to know? If you don't want to know, you have the non-disclosure, or you have exclusion, which I said it sits better with me. It reduces the number of embryos that are available, especially in cases where she doesn't carry the disease. Imagine that if she does not have the disease, these will be normal embryos. You can argue ethically about that. But on the other hand, we're making sure that the embryos that we are testing don't have the disease. And then if she does want to know, let's say she gets tested. So first she has a choice of having children, either naturally or through PGTM. And by the way, naturally, you know, some women will just get pregnant and then get tested in pregnancy. What I look at what does PGTM do? It's actually the amniocentesis before pregnancy. It's testing an embryo. And it's the only way in the world right now to prevent a genetic disease. I'll repeat that because I think that's important. We in the PGTM, with the PGTM technique, right now have the only proven technique to prevent genetic disease. Things will come up, such as CRISPR, embryo editing of embryos. There's now a company that started in the United States. They announced it maybe 2 weeks ago, and there was that old trial in China that got the person who did that spent three years in prison. But for right now, we have the only technique. So that was, I'm sorry, that was the, hold on. Yeah, that was the announcement of CRISPR, but this is CRISPR for Huntington's. So CRISPR this is done in animal models, but with success. You see here, these are the CAG repeats that are the cause of the problem. And through CRISPR technique, which is a modern way of editing genes, they were able to do it. And there are other reports as well. I took the most recent one, which is from this year. What about hereditary cancer? So here is a case of a woman at an age that is already challenging to have a live-born child through IVF. She was over 40 years old, and she was an Ashkenazi Jew. She had breast cancer, had modified radical mastectomy, reconstruction, chemotherapy afterwards, and was on tamoxifen. And the doctors say, you can stop the tamoxifen to try to get pregnant. And she had fertility preservation elsewhere, but only had one embryo that was transferred and was unsuccessful. So basically, she came after the cancer with no fertility preservation, with nothing that was frozen for her prior to chemo. And she was a carrier for BRCA2. Here below, you see the two BRCA genes, BRCA1 and BRCA2, carried on two different chromosomes. And this is what, these are the general risks. First of all, what is the general population risk of breast cancer? Lifetime, quite high. It's 12%. So with the BRCA1 and BRCA2, chances are you'll see reports all over the place. So I gave a lifetime chance of over 80% for first breast cancer. A second primary also happens in a significant percentage. The chance of ovarian cancer, which is unlike breast, which has over 91% overall 5-year survival, ovarian cancer has 30% 5-year survival because it's usually discovered late. And you can see the statistics here. Again, my general thing, what I say to patients is 30 to 40% chance of develop ovarian cancer. And then there are other cancers, pancreatic, and I'm sure my colleagues encounter this, that pancreatic cancer has become now a bigger player in the cancer genetics in oncofertility. We find more genes that are causing pancreatic cancer. Again, a horrible cancer. Most patients are dead by 1 year. So this couple was what I call a match made in heaven, because she was a carrier for BRCA2 gene and had cancer already. Her husband, she was 33. Her husband was only 36, and he already had colon and kidney cancer and had colectomy and partial nephrectomy. And when they tested, and he had a father also and grandfather with colon cancer. So when they tested him, he had the Lynch syndrome. And this is one of the, the letters you see are depending on what variants. Today, we don't say mutations anymore, we say variants. So which variants cause Lynch syndrome? And you can see that with Lynch syndrome, there's over 80% chance of having colon cancer. And you can see that it was full penetration in this entire family, unfortunately. Think about it, like a patient, his father, his grandfather, didn't miss anyone. And then for women, an increased chance of endometrial cancer, uterine cancer, and then also ovarian cancer in some cases. So we actually did IVF on them, and we had to test for the following. Obviously, over 40 years of age, we worry about abnormal chromosomes. We call that euploidy, so we do PGTA, that's the test for chromosomes. And then we did PGTM for those two genes, both of them dominant, so BRCA2 and MLH1, which is the Lynch. So two dominant, meaning that each one will have 50% of the embryos will be affected, and not the same 50% for BRCA and Lynch, and not the same for those who have normal chromosomes or not. We found one embryo that did not have abnormal chromosomes and that was negative for both genes, and it was a male, was transferred, and they had a little boy. That's a genetic miracle. So just a point to say that Ashkenazi Jews, this is actually work from, I believe, Shaare Zedek, where Gheona works in Israel. They took men, Ashkenazi Jewish men, with no history of cancer in the family, and they tested them. And for Ashkenazis, there are 3 founder mutations. I guess we should call it variants this day. But anyway, 3 genes that usually, 3 variants in the genes that cause most of the cancers. And then there is a reflex being tested if those 3 are negative. But in any case, they found carrier males in in 136 guys out of, over 8,000 with no history. Okay. Now, when you find that, also you have to go to the family, because obviously they have family that could very well be affected. So we now know, and this was a very important contribution to the literature of my Israeli colleagues, we now know that Ashkenazi Jews have a 40% chance of carrying the BRCA gene. I contend that every Ashkenazi Jew should be tested for it. Yeah, and this is the paper, the original paper from the woman who discovered it. She was honored again by Obama. I'll give her a lot of credit, McKing. And these are, in general in the United States, you see that the carrier rate is 1 in 300 to 500. And I test every patient. So Marie Claire King is the one who discovered it. And she said that genetic screening for cancer, for these cancers, should be on every woman at 30, which is obviously an extreme approach that I guess most people don't adopt. But I definitely do this for anyone with cancer history in the family, and I have a very broad screening test. So now another ethical dilemma is transferring affected embryos. So we have had, I'm going to give you 3 cases, each of them with a different gene that they request a transfer of an embryo that has the gene. One is this couple that was a carrier for G6PD. So G6PD is a gene on the X chromosome, and only males are affected. And what do you get with G6PD? Not much. It's a pretty mild gene, and it causes allergy to fava beans, and in many cases, which can be hemolytic anemia. So it could be pretty significant, but if you're being told not to eat fava beans, I'm not sure that you'll have to do that. And then the other thing is, it goes along with some allergy to drugs. Very common where Gheona is coming from, and I'm sure she can share her experience. But anyway, they requested, they had only one male. So they wanted a boy, and this couple was extreme. They actually terminated a female fetus. We're not going to discuss that ethical part. They were not my patients then. But they asked for checking. There was only one male. The male was a carrier, and they decided they wanted to do it. So that's one case. The second case, that's important. So let's see if I can go back to this. Yeah. So the second case was, wait. Okay. 2 genetic scientists, very interesting. And his mother had colon cancer, and he was a carrier for FAP. FAP goes for familial adenomatous polyposis, and it's a setup for colon cancer. They did IVF. 2 of them were not affected by FAP. One was had degraded DNA, and the other had monosomy, 1 copy of chromosome 11. So instead of doing another IVF, they wanted to transfer the one embryo that looked, that was normal by chromosomes and was affected, did have the FAP gene. So what happens with FAP, which is an APC mutation, APC, another cancer gene, what is the chance of having colorectal cancer lifetime? It's 100%. However, most patients who are aware of it don't get to it because they get a colectomy their colon is being removed, usually in their late teens. Polyps start at the age between 10 and 20. And of course, they can be followed by colonoscopies. There is such an animal called attenuated FAP, which has a slightly lower lifetime risk, but not that low, 70%. And there are even other cancers, and I'm not going to go into it, but that's a much lower chance. So, good question to my European colleagues maybe is would you do PGD for familial adenomatous polyposis? This is adult onset. You can say it's preventable because you can do frequent colonoscopies and perform prophylactically a total colectomy. The argument against it would be multiple procedures that have some risks, even the diagnostic ones, but mainly having your whole colon removed can give you quite a significant gastrointestinal disability and complications of the surgery. I'm an ex-surgeon as well. I've participated in such surgeries. It's not a walk in the park. I'm also on call, and I'm getting called by my answering service multiple times. So I'll finish and I'll take that call. I apologize. Next case is a BRCA patient, a different BRCA patient than the one I presented. This one already also had breast cancer and had a mastectomy, I believe with reconstruction, and had a BRCA1 mutation. She was 40 when she came to me. And she was even reluctant to have PGTM at all for the BRCA mutation. She just wanted to have her chromosomes tested, and then I convinced her to do it, and she did the test, and she got one normal male that did not carry the gene, BRCA gene, and one normal female that did carry the gene. So she wanted to have it transferred, to have the boy transferred, and she had a healthy boy. Next, she came back to us, and she wanted a female embryo. And she wanted us to transfer the female embryo that carried the BRCA1 mutation. And you see here another graphic to show the chances of cancer, breast and ovarian. And we talked ad nauseum about this. And why? The question is, in general, why would intended parents want an embryo that is affected to be transferred? So the main reason is when this is the only embryo remaining, but also religious and psychosocial beliefs, not leaving an embryo in the dish or tossing it. And there is an issue in ethics called the intentional diminishment. That is that the mother says, I have the gene, so I'm trying to create a baby that doesn't have what I have, a baby that you're saying is better off than me. And then there are cases that I think we all know in our field. Deaf people tend to be in communities, and these communities actually encourage deafness and communicate by other alternative means. So this couple, a lesbian couple, asked to have a deaf child to actually do intentionally screen for the deafness gene. And this couple had achondroplasia, which is one of hundreds of genes that cause dwarfism, and wanted to have a dwarf child. And then you can understand that living the dwarf's life and having a child that is of normal height may have struck them as something that, you know, they don't want, and, you know, puts you as the person who is doing the procedure in an interesting dilemma. So there is a physician-patient conflict, and you can see here, okay, there is the autonomy of the patient, and there is the autonomy of the physician. Where does it put us? And this year, the ASRM has renewed their guidelines, and the guidelines say that this should be considered. I mean, transferring an affected embryo should be considered if there are no affected embryos, if no unaffected embryos are available. All issues of ethics come into play: reproductive liberty, physician autonomy, professional conscience, non-malfeasance, and procreative beneficence. Many genetic conditions also have high variable phenotypes, which might be something that comes up a lot in Europe now that I hear the debates that Dr. Bunnik, Professor Bunnik cited about how they look at genetic diseases. Yes, it is true. And then if the directives of our society is that if it's a life-threatening condition, they're highly discouraged allowing this kind of transfer. Now, if the disease that we're considering is effectively manageable or treatable, on one hand, the patients have the autonomy after extensive genetic counseling to have it transferred because it's her embryos or their embryos if they're a couple. However, you as a physician individually also has the autonomy, and if you don't feel it's right, you can refer to another physician, and our professional society does not feel that it's your responsibility to transfer an affected embryo. They mentioned, the last sentence here is very important, that counseling at the outset, when you start with the patient and you are talking about IVF and she's a carrier or they're a carriers for a genetic disease, you have to tell them, you have to talk to them. And one of the things they should know is that in the genetic selection of embryos, they may have an embryo that's not transferable. So these are the pros and cons, obviously, that we have discussed. You see that you can go either way. And just to remind us that there is a huge spectrum of genetic diseases going from green to red and a lot of intermediates. The significance of the disease and whether you can live with it, number one, normal quality of life, and number two, normal length of life, varies significantly as you travel from left to right. And to sum up, I don't want us to forget to go off the vision. It should be double F. I'm sorry. They make typos even in America. And PGTM, again, I'd like to stress, is the only effective tool to eradicate genetic disease, to effectively stop the propagation of genetic disease from one generation to the next. And that wide use of PGTM will improve quality of life and prolong life. And this is our mission. We are empowering the patient with genetic choices. Thank you very much. I'm done.
Thank you very much, Professor Hershlag, for this excellent presentation. I think it was very interesting to see all the different views from Europe and America. So I think it's very interesting to have both views and discuss about that. Thank you so much. So I think we have still, of course, time for questions and discussion. So, Uma Ramashwani.
Excuse me,
yes.
I'm going to take a call from my
Yeah, I
patient.
know you have to take a call.
I'll be back.
Yeah. Okay, great. Okay. So I think Uma just wrote a few questions in the chat, but I think Uma, it would be fine if you just say it aloud for all of us. I mean, I can read them, but Uma, are you there?
Thanks, Andrea.
Yeah.
I thought it was really an excellent webinar, really thought-provoking. So thank you to all three speakers, Gheona, Eline, and Professor Hershlag. I think one of the questions was really, we talked a lot about ethics, but about sort of what sort of counseling, and do we actually have experienced psychologists and counselors who can work with these families before they consider these big decisions. And I think that's something that's really, I think, is an unmet need for me personally. And maybe that's my first question. The other question was really for Professor Hershlag, but perhaps Gheona and Eline could, tell us how we can improve this. Because I think if you start with, yes, there are some diseases that are lethal in neonates and all of that. But I think we should never forget about the guilt, because many of these later onset variants, or even with Gaucher, the quality of life of many of these patients are brilliant, and they're all, excellent. They go on to becoming scientists, and there is that opportunity. So for me, that was one of the first questions.
I think that you're pointing at something very important. Especially when we're talking about risks and probabilities, and we're talking about diseases that do not have such a very clear vision of something that you as a prospective parent clearly want to avoid for your children, decision making becomes all the more difficult, and the importance of support to understand and also to process and also to help guide the decision making is very important. Yeah. In the Netherlands, we have specialized medical psychologists available, but I don't know if that's everywhere.
No, I don't think we have enough in Israel. It's a very good point. We are trying for couples with decisions like, as mentioned, Huntington, or even that want to prevent Parkinson in Gaucher or so on, that the genetic counseling will explain them extremely detailed, and to ask them not to make a decision on the same moment, to go home, to think about it, if we don't have enough support, or to send them to some psychological consult, and then we'll see them again in 2 weeks or so. So that's not obviously the best thing possible, but also it is something that we are doing. I also want to raise the point that, for instance, for BRCA carriers, what I see, we have a very large group of patients. For adult-onset diseases, there are really, and as you mentioned also, you all say that there will be treatments in 20 years, maybe for some diseases at least. There are two groups of patients that indeed, couples that indeed, as you mentioned, Professor Bunnik will say, what do we have to worry now? For sure, or 90% there will be a treatment in 20, 30 years, or 40 maybe, for Parkinson, even more, And the other group of patients are saying to us, at this moment, I want to do the maximum and the best possible for my future child. And what is the best possible for my future child now is to prevent the disease. So these are mainly the two streams that we are seeing in our consultations for late onset disorders, for Gaucher, for so on.
Thank you. I think, Uma, your other questions are for Professor Hershlag, so maybe we can wait for him for that. And in the meantime, Eline Sidransky. it's
Hi there. I think this was a really interesting presentation, and I commend the speakers for bringing up a lot of really interesting issues. I also want to mention that it is Thanksgiving here in the United States, which is why probably the American audience was limited, because it's a pretty big day for family reunions. I'm really troubled by this discussion, and it's really because we know so little about GBA-associated Parkinson, number one. Number two, the penetrance is really, really low. I don't know, when somebody said that the risk is 15 times higher, I'm surprised at that number. I would probably say it's between 3 and 5 times higher. And, I've been following at-risk carriers that have positive family history of Parkinson's disease, and for 15 years, we've had one converter out of 100. So what you're talking about, pre-implantation genetics for a risk factor for an adult onset disease that can onset in their 70s and 80s, where you can live for, even with the poor treatments that there are today, you can still live a functional life for some years. To me, and if this is kind of crazy, and especially if there's limited resources to start getting into this level of looking for risks. Not only that, you can't counsel a family that their child is not at risk for Parkinson's disease, because only about, even in the Ashkenazi population, only about a third of patients have genetic risks for Parkinson's disease. There's so many other causes of Parkinson's disease, and we don't know if the risk for GBA works in concert with other genetic risk factors that can be causing future Parkinson's disease. So I almost think it's deceptive to tell a family that if they go through this, that they won't have a child with Parkinson's disease, because what you're taking off is just a small portion of the risk.
Thank you very much, Helen. Indeed, very true what obviously you are saying. You are the first one that saw this correlation, and you are researching it for so many years. Just I want to say, indeed, we are not saying that this is important. Yeah, at least we are not saying that we promise a child without Parkinson's disease. Maybe we are reducing. That's all, but yeah, you are right. That we promise a child with Parkinson's disease.
Andrea, you're
I can.
Oh yeah.
Sorry, no, I just want to remark this concept that Ellen said, that the risk for Parkinson's disease in a carrier is not 15, but it's just 3 to 5 times higher. So it's really something, not so high. And so I think this is also something that we have to take into account. And also, Gheona, I'm sorry, I just make a comment. Gheona, it's interesting, this case you presented where you have a father with 2 mutations, N370S, and I think was 84 the Legion GG, yeah. I think. Yes. And so you decided to, the carrier, it was transferred the embryo with the N370S, but we need to remember that N370S, it's also associated with a higher risk of Gaucher disease.
Yeah, absolutely.
Of Parkinson's disease, sorry, yeah.
Between the two.
Yeah, no, of course, you choose between the two, and this, I understood the concept. But the 370S, the N370S, it's an issue because it's a mild mutation, but still is associated with a high risk of Parkinson's disease. So it's a very difficult situation. And even there are variants that are not causing Gaucher disease, and they are associated with the high risk of Parkinson's. So there are also these things that have to that we have to take into account. But it was very interesting, this this family. So sorry, this was just a comment. We have two questions. One is from William Berg. Please, you are on mute. Just yeah.
Hello, everyone. I'm William Berg. I'm a male fertility urologist out in New York and Long Island. I was in and out a little bit, but maybe this was addressed, and it's a little bit slightly off topic, but more in the whole PGTA, PGTM kind of arena and the ethics of it. Obviously, dealing with male factor infertility, I see patients with the AZF deletions, and specifically for the purpose of this discussion, it would be the AZFC deletions, which confer, infertility, essentially guaranteed a high level of infertility for those patients. In the ethics of, perpetuating infertility, essentially. We know, obviously, that a lot of these patients, who require IVF outside of these specific genetic diseases, but require it for male factor infertility, right? It's a global, some sort of genetic cause that we can't pinpoint often. And obviously we can pinpoint the AZF regions, but, when we're just if anyone could comment on the ethics of essentially when you're doing IVF for these severe male factor infertility patients, if they have a male child, there's a good chance you're going to be perpetuating the need for future IVF and the need for potential severe infertility. And I'm curious about the ethics regarding that.
Yeah, if I may respond, thank you for your question. I think this is interesting. We see this happening too in Europe, that there's a lot of discussion about that notion of perpetuating. And even in the Netherlands, there has been a proposal to change the law to actually allow the use of PGT to avoid carrier status in offspring, because people that are affected with genetic conditions may sometimes feel that reproduction becomes a very difficult journey, and then that is being passed on to the next generation, actually. And this purpose doesn't align with the ethical framework and even the legal framework that I've described in my presentation, because we're not talking about a high risk of a serious disease. We're talking about a problem that has to do with procreation, and you're talking about male factor fertility, but you could also maybe extend that to just having to deal with a familial risk that you have to pass on and have to make reproductive decisions surrounding that. And so it doesn't fit within current frameworks, but I am seeing increased recognition of the burden that is associated with these types of problems. And so who knows what will happen in the future there.
I'd like to pipe in. Thank you, Dr. Berg, for your question. He works actually across the hall from me and is my male fertility person. And for your patients, you can benefit from the American approach and not the European one. So two things. Number one is PG, our technology can be used to choose a female. That's number one. That will not have sperm, but will not suffer from it. The other thing is that if the microdeletion is very well diagnosed, PGTM can be done, but it's obviously very challenging. And, I haven't done any of these cases, but maybe we should think about doing the next case. It's hard, first of all, especially with the AZFC, to even find sperm. So if you find sperm, it will be really interesting to actually do this. And male infertility, by the way, to my European colleagues, is a severe condition. It's a condition that affects people's livelihood. It affects their mood. And I think that, it's really interesting for me to see the divide between, why European professionals, geneticists and reproductive endocrinologists think that they should sit like a jury and decide for the patient what is a severe disease and what is not. Where is the patient's autonomy here?
Professor Hershlag, I'm going to intervene here and just ask you a question, please, if I may. So what if this reproductive choice was never a choice for that embryo? He may not want to have children, right? So he may be someone, more and more nowadays, young people, they choose as their own will, at least I've seen this many times, where they don't want to have children. They may adopt. So why would we want to, this embryo is going to be otherwise perfectly fine, going to have a good life. So why would we want to deny that embryo that life? Because we think fertility is the most important thing, because actually many people may not choose that. So sorry, it's maybe a slightly different view, but that's my view.
It's very interesting what you said. And, I believe that ethics of reproduction, probably like most ethical challenges, is not a black and white thing. It's not like, oh, everyone who carries this infertility gene should be screened for. No, it is a choice. The question is, does the unborn child have ethical rights? And that has been discussed by ethicists many times. Most of them say that they actually don't because they don't exist. That's not necessarily how I feel, but that is what reproductive ethicists traditionally have been saying, including Robertson and some other people that I think many of us know. What you said about this is very interesting, and I'll tell you my approach. My approach is I have a very strong tool at the fingertips. And that is, we have climbed on the shoulders of giants, the fact that we're able to determine the genome of an unborn child from a very small number of cells and a very minute amount of DNA has, developed into such a major tool that we have to use it very judiciously, that there is definitely room for good use, but also for abuse, as I call it, and misuse. I firmly believe that in my job, I'm giving the children born to my patients an open future. When you said, what if he decides not to have children? It is a certain percentage of the population, especially if they live in the beautiful background that you see there. I don't know if you're there.
No, not at all. I'm in a dark, wet and windy, and I'm just feeling better using this. That's all.
It's wonderful. So yes.
I'm in London.
I don't think that, you can have Hyde Park next. But what on a serious note, if you go statistically, most men born today will choose to be fathers, or we want to be fathers in the future. Will there be some that will not? Sure. That's why I'm saying it's an open future. I want to open the future for them. Imagine this, let's say we selected this gene out, the mother made enough embryos, this child is now a result of a normal, hello? You hear me? This child is a result of a normal,
Hi.
Are you there?
Shoshi? Yes, Shoshi, you need to, okay, she's mute now. Sorry. Yeah.
Okay. No, I'll finish quickly. So what I'm saying is, so let's say we tested the child. You don't know the unborn embryo if it will be an adult who wants children or not. You take this gene for infertility out of the equation, and then if it doesn't want to have children, so be it.
Can I add something? Just a short comment.
Yes, sure.
Hi, I'm Noah. I'm from Israel as well. I'm a medical geneticist. And I am really concerned about these issues because I feel like that we as physicians, we use this excuse that the parents want to have a healthy child, the parents want to have the best baby ever, but we forget, I think, that we have also a responsibility for the society and for humanity, really. And I really feel that we cannot intervene in every field of, I mean, the technology exists, it's true, but I don't think that we have to use it for every, I don't know, every question, for every thing, I don't know, everything. I don't know what to say. I mean, if a parent does not want to have a child with glasses or with curly hair, you know, it's just the slippery slope that you talked about. It, I think we're there.
Yeah.
If we don't want to have a child with 10% risk of having Parkinson at the 60s, I don't know, what are we doing here?
Yeah. Thank you.
And we are doctors. We're not here to improve. I don't know. I feel we are touching I forgot the word, but eugenic. Yeah, we're touching eugenic. We just don't say that we are doing it because we're giving the responsibility to the parents. But I feel like we have to take responsibility in ourselves. So that's my comment. Thank you.
I wanted also to add, thank you, Noah, that sometimes I'm feeling that the patients that require IVF anyway get kind of a bonus when you go for, you know, like things like this, like the case that I presented that the father was a compound heterozygote for Gaucher disease, and I mentioned they needed IVF anyway from other causes. So I'm not sure if this couple would be fertile. They would come to us. We would agree to do it anyway. But it was much easier, let's say, even for medical. For the medical surroundings, for the physician, anyone to say, okay, anyway, they are doing IVF. So what's now the big issue? We know that the biopsy does not harm the embryo, so it's not something wrong to do it. And really my question is to Professor Bunnik, if she doesn't feel also that why should the ones that require IVF for other reasons get this bonus that is easier for us to agree for them to do PGDs and the ones that don't need IVF. Anyway, obviously there is a small risk of the IVF, all of us we know, but it's really very, 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 very small.
Yeah.
So
I think that you're raising a justice concern here too. So why would only the ones that are already having this medical indication for IVF be able to access this technology and others not? I think that this justice concern works only to the extent that the service that you're offering there is in fact something that is very, very important, something that other people would also want to be able to access for their children. And especially the case that we're talking about today, I don't think meets that requirement. And so I think that this notion of contextual proportionality allows what Professor Hershlag is underlining, that reproductive autonomy, that desire of the individual to make use of this technology, it allows more space for that, especially in restrictive countries, more space for reproductive autonomy. But when we decide together that some form of screening is very, very important. We should indeed not offer it only opportunistically to the ones that are already making use of this technology, but we should see if we can make it available to the entire population. But I don't think that risk reduction for Parkinson's disease would be a good case for this. Yeah.
Okay, thank you so much. I don't know, I think Dr. Hershlag wants to say something because we are almost finishing. So yeah, please.
Well, this discussion is very enlightening, and I think it's really, really important for us who have similar technologies, but maybe somewhat different approaches, to have an open discussion. And very recently, I met with a director of a PGT lab here who also has labs in Europe. And we decided, and I want to collaborate with you guys if it's possible, to actually screen all the policies towards PGD or PGT in different European countries, and maybe in preparation for ASHRA that is coming up soon. So I'd love to contact you, and with Gheona we'll be in touch. I want to comment two quick things. And Noah, I don't know if she's still on. I heard what you said with great interest. Nice to always meet a new colleague, geneticist in Israel. All power to you, and hopefully we'll have more encounters. I agree with some of what you said, and it has to do a lot. I actually prepared for another webinar that I'm doing with the Hastings Institute, which is all ethics. And I was looking up a lot what's happening these days with the PGTP, which is that new thing, polygenic for polygenic disease. And I think we can now distinguish between two entities that exist in the market right now. One is PGT for disease, which is either monogenic, one gene, or polygenic. And the other one is what is evolving in the market. And this is like, if you want, Silicon Valley companies that are now trying to do PGTP for traits, which you mentioned. Okay, so there's several companies now that offer genetic testing for IQ, for height, for eye color, and even promise you they'll tell you about your longevity. And I think we can make a differential, an ethical difference between the two. Whether or not this specific gene that we're talking about today, which is the Parkinson, the increased chance for Parkinson that goes along with some Gaucher, that's a very specific subset of the overall numbers of genes that we deal with that all spell out the chance for disease. They are not eugenics. The issue of genetic eugenics, I think, is extremely dangerous. And I think, that's where I'm feeling that all of us could meet and just say, we would do it or consider doing it if you're in Europe for disease, but not for traits. And there is one last thing that I'd like to say, and that is access, which was raised before. And I think access to care in general puts us Americans to shame, because obviously healthcare leaves a lot to be desired. Healthcare systems are much more universal in European countries and elsewhere, Israel as well. And unfortunately, my patients, if they are not covered by their insurance company, have to pay a lot. And therefore, there is the risk of having two classes, the genetically tested and the genetically untested. And that is a dangerous thing that I would strive as someone who carries the torch of reproductive genetics to fight and to find a way to overcome it.
Okay, thank you so much for these comments. I think what you are saying is about these companies is quite scary. So I think it's good to know and to discuss about this. And so I think this is was a very nice opportunity to see all these views and to discuss. There are so much to discuss, to decide. I think now as a group have the responsibility to do some kind of guidelines or a position paper on this. And of course, we will go on to this. I would like to thank you so much, Gheona, Dr. Hershlag, and Dr. Bunnik. It was extremely interesting to hear you and all the participants for the discussion. And Gheona, if you want to say a few words to close the webinar.
Thank you very much. We'll be very happy to collaborate together on a statement from the Gaucher organization, as you mentioned, Andrea. Uma, you wanted just to say something? Okay. And we'll be in touch, yeah?
Okay.
Thank you so much.
Thank you. It was excellent. Thank you. Thank you very much.
Thank
From
you.
London, not from the Caribbean.
Okay. Thank you so much.
Bye-bye.
Bye-bye.
Take care, everybody. Bye.
Thanks. Bye.